Now the third stage of primary angle closure glaucoma. Okay, as in the previous lecture we have discussed the second stage, the subacute stage. Okay, so what is the third stage? How the second stage becomes the third stage, which is called primary acute angle closure glaucoma or primary acute congestive glaucoma. Okay, this third stage of the primary angle closure glaucoma, it is characterized by sudden and severe elevation of IOP. The intraocular pressure rises suddenly and severely, which causes severe clinical features. Okay, so the pathogenesis, remember, the pathogenesis is similar as to stage 2. So let's rewind stage 2 in few words. Okay, in order to understand the pathogenesis of stage 3. As we noted, due to developmental anomalies in these people, when there is the mid dilation of the pupil, okay, mid dilation of the pupil, mydriasis, because of the reading in dim light or screening in dim light or the use of mydriatic drugs. Okay, so what will happen? The iris will come near to the lens. Because of this mid dilation pupil and developmental anomalies, the iris will come near to the lens, and it will cause a partial block. Okay, a partial block. The outlet is partially narrow. This is called relative pupillary block, as the pupil is partially blocked by this mid dilated pupil. So what is happening? There will be the accumulation of aqueous humor. Because of this partial block pupil, the fluids will accumulate, the aqueous humor will accumulate in this posterior chamber, and it will push the iris toward the interior chamber angle. Okay, the iris will be pushed in a dome shaped pattern. Okay, this dome shaped pattern is called iris bombay. Because of the accumulation of the fluid, now the iris comes to the interior chamber angle. Okay, and this iris bombay has now blocked the interior chamber angle and hence trabecular meshwork, which will cause the accumulation of this aqueous humor. Okay, the aqueous humor will now accumulate in the interior chamber and the posterior chamber, and it will suddenly elevate the intraocular pressure. Okay, but we know that in the second stage, when we expose the patient to bright light or when a patient goes to sleep, it will terminate this iris bombay because of the meiosis. Because of the meiosis, as the iris will contract, okay, and it will cause the meiosis, pupillary constriction, which is called meiosis, which will terminate this iris bombay, and the episode will be terminated. This is about in stage 2, when we expose a patient to bright light or when he or she goes to sleep. But what is happening in stage 3, in the primary acute angle closure glaucoma? It is happening that sometime or due to some severe anomalies in some people, this increased intraocular pressure will cause the ischemia of this iris. When this iris bombay become ischemic, what will happen? Now it is unable to come to its original, to cause the iris is unable to cause meiosis and terminate this bombay, because the ischemia, the IOP has elevated to such an extent that it has caused the ischemia of the iris. And when the iris is ischemic, whatever we do, we expose a patient to a bright light or when a patient go to sleep, nothing will happen because the iris is ischemic. So this is the stage 3 of the primary angle closure glaucoma, and this iris bombay will remain in this state, and it will cause the severe elevation of intraocular pressure. That's why it will cause severe clinical features. So now how the patient will present to us? How? First of all, we know that the IOP, the intraocular pressure, can reach in this stage 3 up to 70 millimeter of mercury. Okay, it become 2 times as compared to the stage 2. So it can reach to 70 millimeter of mercury, which can cause the edema of the cornea. Okay, as there will be the decompensation of the endothelium will decompensate, okay, because of the increased intraocular pressure, and it will cause the edema of the cornea. The cornea will become edematous. So this edematous cornea, we know that in every corneal disease we have pain, photophobia, blurred vision, lacrimation, redness, foreign body sensation, watery discharge, okay. So with corneal edema, these symptoms were also present. Okay. Now, because of this intraocular pressure, there will be the irritation. The corneal nerve will irritate. Okay, this increased intraocular pressure will irritate the corneal nerves, and hence this irritation will cause two things. First of all, it will cause pain, ocular and periocular pain. The pain around the eye, okay, and inside the eye, and we will have blephrospasm. Because of this irritation, the eyelid will close up. It will close up and it will close the eyes spontaneously. This is called blephrospasm. Okay. Now, this edema, and in the early stages, this edema, and in the later stages, the entropy of the optic disc and optic nerve will cause the visual acuity to drop to such an extent that it will become limited to the handshake. Okay. So the visual acuity may reaches up to 6/60. Okay. And now when we will come inside the eye. First of all, we discuss the edema. Okay. Now there will be because of the ischemia in the iris. What will happen? There will be atropic white changes in the iris. Okay. We will have white atropic changes because of the ischemia. Now there is the entropy of the iris. Okay, so we will have white atropic changes. We will have conjunctival redness. Okay, we will have conjunctival redness because of this increased intraocular pressure and because of the iris ischemia. The conjunctival blood vessel will dilate and will cause conjunctival redness. We will have circumcorneal congestion. And remember, there can be the opicities in the subcapsular opicities. Because of this increased intraocular pressure, we will have subcapsular opicities. These subcapsular opicities in the anterior pole, these are called glaucoma flicken. Okay. So, and remember, as the iris is ischemic, so when we try to dilate or constrict the pupil, it will non-reactive to light. Why? Because the iris is ischemic, so it will non-responsive to light, and hence the iris will remain in a mid-dilated position. Okay, so we will have mid-dilated iris which will non-reactive to light. We will have mid-dilated, non-reactive to light, okay, iris or pupil. So these are the clinical features. These are the severe clinical features because of the increased intraocular pressure, which will cause corneal edema, irritation of the corneal nerves, conjunctival redness, atropic changes on the iris. We will have glaucoma flickens, the subcapsular opicities, okay, and the visual acuity may reaches up to 6/60. Okay, so these are the clinical features to which the patient present to us. Okay. Now, how can we diagnose the condition? The condition can be diagnosed with gonioscopy. As the in gonioscopy we evaluate, we analyze the interior chamber angle, and through gonioscopy and tonometry. Tonometry will give us the estimation of the intraocular pressure. Okay, so we can use gonioscopy and tonometry. Okay, now treatment. How can we treat the condition? Remember, it is an ocular emergency. What it means by? It means that if we do not manage the condition properly and timely, in this stage 3, it will cause complete blindness. Okay, so it is the stage in the primary angle closure glaucoma which needs proper attention. Okay, it needs proper attention. Now that's why we will start the treatment from systemic therapy. Systemic therapy is due to because of the increased intraocular pressure. If the intraocular pressure has elevated to 70 mm of mercury, and this will cause the ischemia. So to the topical therapy, the iris is non-responsive because of the increased intraocular pressure and ischemia. So what will we do? In order to drop this intraocular pressure below 45 millimeter of mercury, we have to use systemic therapy. When we drop the pressure to 45 millimeter of mercury, below 45 millimeter of mercury, then it will become responsive to topical anti-glaucomic therapy. Okay, so we will start from systemic therapy, and even first of all we will start intravenous acetazolamide. Okay, acetazolamide is a carbonic anhydrase inhibitor, okay, which inhibit the production of this aqueous humor. So we will first start the acetazolamide intravenously, and after that we will also give oral acetazolamide in order to drop the pressure to below 45 millimeter of mercury. Now, if to this carbonic anhydrase inhibitors, if the pressure is not decreased, then we will use hyperosmotic agents such as mannitol, glycerol, isosorbide nitrate. Why? These hyperosmotic agents will increase the osmolarity in the blood. Okay, the osmolarity will be increased, and when there is the osmolarity in the blood is increased, then it will draw the fluid, it will inhibit the production as well as it will draw the aqueous humor toward the blood. Okay, it will draw the aqueous humor toward the blood and will remove the extra fluid. Okay, so if acetazolamide group is not effective, we will give the patient hyperosmotic agents which will decrease the pressure by these two mechanisms. Okay, so this is the systemic therapy. Now if the pressure goes below 45 millimeter of mercury, what will we do? We will start topical therapy, and the drug of choice in the primary angle closure glaucoma, especially in stage 3, is the pilocarpine. Okay, pilocarpine is agonist. It is cholinergic agonist, and what will it do? It will cause pupillary constriction. Okay, it will cause pupillary constriction and we will terminate this Bombay. Okay, and will terminate this Bombay. So the angle will open and it will drain the fluid normally, and the intraocular pressure will further decreases. Okay, and with pilocarpine, alternative drugs are beta blockers such as timolol, levodopa, okay, betazolol. We can also get alpha 2 agonists such as brimonidine. Okay, alpha 2 agonists will also decrease the aqueous humor production, and we can also, as first of all we have given systemic acetazolamide. Now we can also get topical carbonic anhydrase inhibitor. Okay, so this was about the treatment of primary acute angle closure glaucoma. Now, as we know that these patients have developmental anomalies, so this attack can come in the future again. So what will we do? We should take proper measure in order to prevent the future attack. So to prevent the future attack in the same eye, what will we do? We can do two things. In this same eye, we can do, first of all, remember, as these patients have narrow angle because of the developmental anomalies, okay, these patients have narrow angle, narrow anterior chamber angle. So through gonioscopy, we will take a look through this anterior chamber angle. If the angle is closed, less than 50%, we will do laser peripheral iridotomy. What is this? Through laser, we will make a pore in this peripheral iris. Okay, this is called laser peripheral iridotomy, which will directly drain the fluid to the anterior chamber and hence to the trabecular meshwork. And if this angle is closed more than 50%, then we will do a surgery which is called trabeculectomy. And trabeculectomy, we are directly connecting this interior chamber, okay, this interior chamber to the subconjunctival space. Okay, these surgical procedures, as I told you, these will be discussed in details. So keep in mind that this is a surgical procedure and which will directly connect the anterior chamber to the subconjunctival or subtenon space. Okay, and plus in trabeculectomy we will also remove some portion of the peripheral iris, which is called surgical peripheral iris iridectomy. We removing a portion of the iris surgically, okay, in order to make a hole, and the fluid will directly bypass this pupillary outlet and will come to the anterior chamber and hence to the subconjunctival and subtenon space. So these are the prophylactic measure we are taking in this the same eye in which we have got this condition. Okay, now as these people have genetic problems and developmental anomalies, so this attack can also happen in the normal eye. We also have to take measures in the normal eye in order to prevent this attack in the normal eye. So for the normal eye we will do two things. For the normal eye we can do this same procedure, laser peripheral iris iridotomy, okay, and we can make this port through the laser, which is called laser peripheral iridotomy, and we can also remove this portion like in trabeculectomy, okay, through surgery, which is called surgical peripheral iris iridectomy. Okay, so this was about the stage 3 of the primary angle closure glaucoma.